Good evening, everyone. Thank you so much for joining us tonight. Before we get started, I would like to share a brief disclaimer with you, and that is that you are joining us for the Pharmacist Virtual Learning Experience brought to you by Mandells Clinical Pharmacy. It's intended only as an educational program, and the point of this program tonight is a little bit different than some of the ones that you may have heard before. We are going to be doing a wide open overview of all things fertility, Fertility 101. And this side, we're going to be taking it from the point of view of the nurses. So we've done programs before, and you've probably attended some of these or heard these before, talking about from the patient's point of view. But for tonight, we really want to have a panel of nurses talking to nurses amongst nurses. So our esteemed panel tonight will be joining you from all around the country, and we'll be talking about some topics that you may have written in earlier, questions that you may join us on Facebook or Zoom tonight, and you're sharing live during the program. All of this will be recorded so that you can check it out on demand later on and maybe just do a refresher course over time. But the point is really to educate you and do a safe space for all of us to get together within the industry and ask questions from some experts and maybe learn from one another as we can. So thank you once again for joining us tonight. And my name is Craig Orapello. I will be the host tonight, representing on the Mandells Pharmacy side. But now let's turn it over and introduce the nurses. So nurses, if you guys could flip on your cameras and we'll do a quick introduction, everybody. There we go. All right. Here is our panel for tonight. So thank you, ladies, very much. As always, and we've done this is our second nurses panel that we're doing, but our first time live. So I have said in the past that there is no way that I can remember enough to give you guys the introduction that you deserve. So I will be reading it. So bear with me if it looks like I am reading. It's because I am. So first off, in just starting going through in alphabetical order, I would like to first introduce Dr. Karen Hammond. And Dr. Karen Hammond, a board certified nurse practitioner, a recognized leader in reproductive endocrinology and infertility. She's lectured at numerous state, local, national, and international nursing and medical meetings. She's worked with fertility advocacy nonprofit organizations for more than 3 decades. So thank you so much, Karen Hammond, for joining us tonight. We appreciate it.
Thank you for having me.
Perfect. We are so excited to hear more from you guys as we go. So just if I forget anything, feel free to bring it up now. You can bring it up later. We can ask each other things about it. But moving on to Wanda Hofkesang, I want to thank you very much for joining us. And Wanda is a change of career nurse. She had a business administration degree in finance and realized nursing was a better fit. And so thank God for all of us that she realized that early enough on, so we get to work with her. She's been a nurse for 27 years and 20 plus years as a fertility nurse. And she works in the northern New Jersey area for all that time with various practices and been at her present clinic for 12 years now. She is originally from Massachusetts, so we won't talk about that anymore because we have a bit of a thing going on today. It's fine. Sports is not working out well for me, but congratulations to all of you guys. Thank you very much, Wanda, for joining.
Thank you, Craig. Happy to be here.
All right, so let's see. Now, moving on, Roxanne. I'd like to welcome everybody to meet Roxanne Kennedy. Roxanne Kennedy is RN and IVF coordinator. She's been an REI nurse since 2010. So very short and sweet, get right to the point. So feel free, Roxanne, if there's other things you want to share throughout the course of the program, that is what she told me to say. So thank you very much, Roxanne, for joining us tonight as well. Let's see, moving on, we have Morgan Mayo. So Morgan Mayo, normally one of our hosts as well, is also now joining the nursing panel for the first time. And so Morgan has been doing fertility nursing for 8+ years, getting her nurse practitioner in women's health starting in the upcoming spring. She's from Texas, but now lives in Denver, Colorado, and loves the mountains. So thank you very much, Morgan. I feel like sometimes I'm reading off ones that sound like a little like your profile on Facebook or something, but I like it. It's fine. But now we all know.
This side of the screen too, or this side and not running it. It's way less pressure. So I'm.
It is way less pressure. Thanks for reminding me. Now all the pressure's back on me. I thought I had taken a break from this, and I'm back. I'm back in again. All right. And last but not least, Tony Newman. Thank you so much, Tony, for joining us tonight. Tony is a nurse from the New Orleans area who practiced ER nursing before getting into the fertility field about 3 years ago. Fun fact, she was actually a patient at her current clinic prior to becoming a nurse, which is awesome. So you come from both sides, which is perfect. You'll be able to share a little bit of perspective there. And she does know what it is like firsthand to be that IVF patient, but also has her own wild children of her own that she can bang due to science. So thank you very much, Tony, for joining us tonight. Ladies, I want to say thank you to everybody for, bringing your expertise. A big part of this program is really just, it's just the dialogue. That's what we're really here about. So we do have some questions, like I said, that were written in advance from some of our nursing colleagues from all around the country, and I will get to some of those. We're also, as we mentioned, live streaming this on Facebook and Zoom, where we have people asking questions there as well. So if you've ever attended one of these pharmacist programs before, you will know that I'll be able to chime in with those questions. But most importantly, it's just for you guys to kind of dialogue about Fertility 101 as it strikes you. What are the things that if you're sitting and talking to one of the brand new nurses, or if the questions that you had when you were that brand new nurse that you wish somebody could answer for you, we can just kind of go for it. So the perfect time for me to say, I will now turn off my camera. I will say goodbye through the magic of technology and allow all of you to just start talking about Fertility 101. But I will start with a very basic question just to get things started. And this is one that came in a couple times over. The question is really just understanding when patients are asking, like, how old is too old to seek fertility treatment, and up to what age will patients be able to use their own eggs? So just kind of throw it out there to get things started. And then from there, we'll see where the story takes us. So thank you very much, ladies. I will be here if you need me, and take it away.
Who's going to go?
Karen, you spoke first last time. You want to kick us off again?
Sure. So, it's kind of an interesting question, and one that I hear from patients and nurses and other staff members alike is, how old is too old? Well, the thing I tell my patients is everybody is different. The likelihood of one person getting pregnant is much different than the likelihood of someone else. So it's going to depend on a patient's individual ovarian reserve and her other risk factors, like her history of smoking, her BMI, has she been pregnant before? So we always start out with a careful history. And one thing that I learned early in my career is you never say never and you never say always. So we have, unless we have a crystal ball, we can never say you will definitely get pregnant or you definitely will not get pregnant. I tell my patients that the first thing we're going to do is a careful history. I was taught in school, and I bet you were too, that if you listen to your patients, 9 times out of 10, they're going to tell you exactly what's wrong with them. So a patient yesterday who came from far out of state, who was just looking for answers. And gosh, I just said, tell me what's going on with you. And in less than 10 minutes, I already knew in my head what her diagnosis was, or diagnoses. She had a couple of them. So listen to your patients, see what their ovarian reserve is. And I think my other tip is, at the end of the day, ask patients what their goal is. If their goal is to have their own biological offspring, and that is most important to them, or if they want to have a child that is genetically related to both them and their partner, it's much different than if their goal is just a parent. And those goals can change over time. So with third-party reproduction, we can extend the reproductive age limits well beyond what we probably should or would do. But patients generally can be given other options if they have exhausted their own fertility. So that's a great question. I appreciate whoever wrote that one in. Other comments, ladies?
I know at our clinic, which I'm sure many other clinics have similar guidelines, but we actually have an age cutoff for women using their own eggs for IVF. And a lot of it has to do with statistics and what we know about egg health being correlated with the woman's age, and just, looking at SART statistics and things like that. But a lot of it, too, has to do with medical futility. And if 47-year-old woman wants to come and use her own eggs, we do know about statistics and what that will show us and the chances of conception. And so, oftentimes it can be a harsh truth to hear, but we do try to guide our patients to make the best use of their time and their resources. And if the goal is just to parent and you don't care how your family is formed, then we'll often try to guide them in that way instead, to just, again, make the best use of time and money. But some women also need to know they need to try, and we respect that too. So yes, we do have cutoffs, but a lot of times they're not hard and fast, and there are some times where we'll have patients who just need to know, they need to try, they need to have that closure cycle to know for sure that they've done everything that they can before moving on to other options.
I agree. Yeah, I was sorry, Morgan. I agree too with what Roxanne said. I mean, we do have the age cutoffs as well, but I think that patients often have to, like Karen said, it's almost their story is what sort of leads them into how far they'll take something and how much treatment they might need to go through to sort of validate when they might need to change course. So that's an important aspect of it, is maybe figuring that out, and by working with them and talking to them and like Karen said, listening, I think you can hear the story a little bit better and maybe be better off able to guide them then with whether to continue treatment or whether to look at other options, avenues of donor egg or to adoptions and such, because there are other ways to have the family unit, but it's just really important to figure out where that couple is at and that woman's at.
No, I totally agree. And also I think like Karen and kind of all of you are saying as well, is every patient's so different. You can have a 23-year-old who has premature ovarian failure, or a 43-year-old who has PCOS and has a billion eggs. So I think it's hard to pigeonhole them into any age range where this is your cutoff or this is too late. Obviously there is like that upper end where the statistics show, like Roxy was saying, that, Roxanne and Wanda are both saying that there is that age limit, but that no patient's the same. And it's like, I think any of our doctors or any of us would tell our patients that we just need to check out your stuff and your history and then kind of make a fair judgment on that call.
Yeah, this is the same thing in our clinic. We also have kind of like an age. We kind of screen when they call for a new patient appointment. And typically, if they're over 45, we'll have our third-party coordinator kind of reach out first and just feel them out, just to maybe have the conversation that it might not be possible with your own eggs, but where are you at with that? Interesting enough, though, and y'all can weigh in on this, I find since probably the pandemic, we have had an influx of just egg cryopreservation cycles. So many egg cryo cycles. So to me, it's like, people are trying to figure out what they want to do. They're not sure yet. So they're just going ahead and doing this earlier, and just starting that process a little bit sooner. So we were talking about that the other day, how interesting it is, like how many more egg cryo cycles we are seeing come through our clinic.
Yeah, we've seen the same thing too. I think it's great for women to kind of realize that they don't know necessarily where their life is going to go, and to take control and ownership of it. And I think honestly, so many of these women don't even need to use their eggs, but they have that insurance plan. They have the backup plan, and they can use them when they want to, or they might never need to. But I think it's wonderful especially we've seen a lot more insurance companies actually wanting to cover that, and kind of realizing that let's spend a little bit of money now rather than a lot of money later, and save everybody some time and heartache. So I think it's wonderful.
We've had some egg cryo as well, but what I will say is some of it's been some oncology patients. I've seen a little bit more of that in our area. So there's obviously, what I think though, the take home for that is positive is that oncologists are really, knowing what to guide these women with before treatment. So that's actually, you might think that's a negative, but it's actually, I feel like that is a positive from the community, the medical community, and helping women realize how to preserve the fertility before they undergo treatment. So egg cryopreservation, whether it be elective or sort of kind of have to move that patient through quickly because of time constraints with treatment, we've seen some increases as well on both ends, but a little bit with some oncology stuff too.
Mhm.
No, we have seen a huge influx of egg freezing too. I also think like social media plays a huge thing, and like celebrities or social media influencers are posting like, now you can get those mail at home kits and check your fertility levels. And I think it's just a huge thing that egg freezing wasn't popular, 10 plus years ago. And now it's becoming more as women realize that, that you don't have forever, that our eggs are on a time clock. So I think it's super empowering for women to do it, as like more and more knowledge is out there. And also like the science behind it is getting so much better with egg freezing, which is super exciting.
Mm-hmm.
One quick thing I was just going to say, by the way, I wanted to throw in, and excellent answers, ladies. Thank you so much. I just did want to remind everyone, not only if you're joining us on Facebook, I mentioned you can write right into the chat, but if you're also joining us via Zoom, you can also put your questions either into the chat or the Q&A, and we will get your answers handled in both places. And so one quick thing that came in, and this is actually a pretty good, just kind of like stepping stone from talking about the getting patients started on and understanding where the beginning and the end process is. The question came in a couple times, is infertility just in general becoming more prevalent or more common? Is it something that we're dealing with more now than we were in the past? Just love to hear you guys' answers on that.
That's a great question. It's a question that I get fairly frequently, especially from people that aren't my patients. And people say, "Oh, I never used to hear so much about infertility, and now I know so many people that are walking the journey." I think there are a few things that are happening. Of course, the age of first-time motherhood has gone up over time. And I think, though, that probably the most significant thing, notwithstanding that, is people are more open about talking about it. As we mentioned earlier, social media has a lot to do with that. Celebrity news has a lot to do with that. And I think once somebody starts talking about it, they hear more and more just about how many people really are struggling. And I think that is a benefit for people that do feel comfortable talking about their own fertility concerns. It can really be a huge help to their friends and family members, and they can help to support others through their journey, as well as help to correct some misinformation and some myths that are out there.
Mm-hmm. Yeah, I think all those points are spot on. We definitely see that, probably globally, there's a push by 5 to 10 years of delaying starting their family. And so that does make a big difference. I mean, there was a time where women started having babies at 20, 21 and were done at 30, and who knows when they would have been infertile after that. They were done. They weren't trying anymore. So, it certainly is that in conjunction with people being more open and willing to talk about it. And it's interesting, you guys may have seen this too. We have a lot of patients who come through and work full time and aren't comfortable sharing their story with their manager, and they're not really sure how to address, being away all the time and coming in for all these treatments, and where are you going? What's wrong with you? And I do often talk to my patients and explain to them, like, you'd be surprised, if you feel that it makes more sense to just be open and honest with your employer, you'd be surprised who's on the other end of that, and how many of those people have actually been patients and been on the other side and totally understand. And that stigma is starting to go away, which I think is great, because nobody wants to be alone in this. It's nice to know that there's someone else who's been through that same journey as you have. Tony, you've been there.
That's a good point that you bring up, because the age of the first-time motherhood is certainly going up. And I know, as my career has progressed over these last 37 and a half years, I have seen people get a bit older. But I think part of that is too because we have more options to offer. Mm-hmm. Keep in mind that the first IVF baby in the world was born in 1978. That's no time ago, really. And to see how far our field has come in that period of time, we have so many other options that we can offer people, including people that are a little bit older.
Mm-hmm.
What were you going to comment, Tony?
No, I was just going to say, I was an IVF patient in 2014, and I remember working in the ER, and I was kind of embarrassed to say anything because I didn't know if people would quite understand. And it's a lot of information for someone on the other end to take in. And I remember there was another nurse that had just had her children, and I was like, I had just started working that job. So I was so excited when I heard that, and I like caught up with her in the break room, and I was like, oh my God, I'm going through fertility too. And it's like, you feel like you need an outlet because people that aren't going through fertility, I mean, it is different. They try to understand, but it is a whole nother lingo. I mean, just going from nursing from ER to fertility, I mean, it was a whole new world for me. But now I see so many like friends and family going through it. I agree the conversations are being had more. Social media is playing a big part in that. And it's interesting, in our clinic, we have a few new nurses that, we're starting to hire some new nurses. And I was going through the schedule the other day, and, we see new patients in the afternoon, and we're seeing probably 5 to 6 new patients a day, 4 days a week. And to me, that's just mind blowing that there's just so many people that need this assistance, So when you think about, we talk a lot about environmental factors at their first new patient appointment, just things that they can be doing to increase their egg quality, things that they could be doing that could be decreasing it. Smoking is a big thing. We have to counsel a lot of patients on smoking cessation. Not as much. We don't see as much smoking, but every once in a while. But that is a big factor in egg quality. Of course, you have other things like male factor and PCOS and stuff that play into it, ovulatory things. But it's pretty interesting. It's a really, really nice field to be in. And then being on the other side of it, I think has really helped me be a little more understanding as well.
Mm-hmm.
And also think, Karen said it's the science behind it it's not so much even like with infertility, but people who have like chromosome issues or, genetic issues that now like we're able to screen that, and we have an influx or even screen out cancer genes. Like I can see that just continue to evolve and become more and more prevalent, which is really exciting. I feel like in the field, because I feel like a lot of our patients are coming for that, just like, they're doing panels or their OBs are educating them, OBGYNs to, talking about getting pregnant, and they find out they're carriers or something, and they come in. And so I definitely feel like that wasn't something that was popular or as popular even 10 years ago when I kind of started it. I think those kind of things are just becoming more and more, science is evolving and becoming more detailed, and there's new things that they can detect and to help have a healthy pregnancy. So I think that's also a key factor.
I think Karen can probably agree because we've both been in this for quite a while, but OBGYNs are definitely a lot different maybe than they were years and years back, because they used to dabble a little bit in a Clomid IUI cycle with their patient or Clomid intercourse. And so I don't think we see as much of that, because I think the OBGYNs and I think the REs have created a relationship and a rapport to really, the REs are trying to educate, the OBs and GYNs to maybe lay a little groundwork, but, don't let your patient linger there in your hands and hand them over to the RE clinics to be able to guide them further, not wasting time too. So I think that maybe has been helping patients get to the IVF or the clinics, the fertility clinics a little bit sooner as well, rather than like they used to be a little bit more of the GYN, and maybe there wasn't quite the right treatment for them at that time that they were trying to do. They were trying to be helpful, of course, not to put the OBGYN down, but I think that they're happy to kind of let that take that on. I think they're happiest to, do the REs and let them take it over as the specialist, which Karen, you probably could attest to as well.
Absolutely. It's kind of funny. When I first started, laparoscopy wasn't being done. It certainly wasn't being done for any treatment for a while. Maybe a diagnostic laparoscopy, but you couldn't go in and do it to fix anything. And I remember a common treatment for PCOS was doing a laparotomy, making an incision like that across a woman's lower abdomen and cutting out a wedge of the ovary. It's ovarian wedge resection, just to make fewer follicles or fewer, make PCOS a little bit better by taking out a big chunk, a big wedge of the ovary.
Mhm.
Now we think, oh my God, you mean you'd put somebody through a major surgery, remove part of their ovary, dang though, if sometimes it didn't work. Of course, they had scarring, and IVF was pretty much in its infancy, and the pregnancy rates were, gosh, if we got, I remember when we first got in the double digits with pregnancy rates, we thought we were something else, and took a long time before they got to where we are now. So we're certainly, surgeries aren't even done very often now in our field, and certainly we're not going in taking out chunks of patients' ovaries. It's kind of, y'all were laughing, and it's comical that we were doing that.
I just don't know how you would explain that to a patient being, you want to be pregnant, let me cut up your ovary.
Exactly. That it kind of made sense. If you've got too many follicles, you take out part of your ovary. As it heals up, there aren't going to be as many follicles there because there's not as much ovarian tissue to have it. I think it'd be a hard sell now, and thank God for that.
Yeah.
Let's not bring it back.
Yes.
I don't think the women want to give up their eggs.
Speaking of, dealing with some of the more difficult parts of it, right? Like you guys are saying, and a big part of like getting used to the fact that we're just dealing with, understanding more about it and all of that's that comes along with that is that people are more comfortable sharing their feelings now. And so one of the questions has come in many, many different ways. And so I'll just kind of try to encapsulate all in one, but really most of it is just people asking, when you're just getting started in this, how do you deal with those patients that are really struggling emotionally, whether it is because they didn't, because they just found out in the first place that, that they're infertile, or it's because of something else, like of a cancer diagnosis, or because they, aren't pregnant or lost the pregnancy, or any of the number of things. Just how do you deal with that when you're a new nurse and you're just trying to understand that conversation and how important that really is to helping guide somebody towards the next steps?
I think the first thing that new nurses need to realize when they're getting started in practice in reproductive medicine and infertility is that the patients are so often going to know much more than they do. It takes a long time to where you really feel like an expert. And even still, it is a work in progress. It's important to realize that if you look at grief scales, and Ali Domar up in Boston has done this quite a bit, looking at grief scales, and the grief of infertility is right up there with a loss of a parent. And these people are getting reminders of it every day in all facets of life. Maybe it's helpful with a pandemic and people staying in more. Otherwise, they go to the grocery store and everybody looks pregnant. They go to the mall, everybody looks pregnant. They're getting yet another baby shower invitation. They're have a coworker that is announcing that she didn't want more children, and dang if she's not pregnant. So it's everywhere. It's in their face all the time. And we all have different coping skills that we use to help us as individuals to deal with some of these implications. Some people it's to talk about it. Some people it's to talk with their pastor, their clergy. Some people is to get therapy. I remind people all the time that there's no shame in seeing a counselor. The pain is real and the struggle is real. Some people do well with meditation and yoga, exercise, but I think it's important that we talk to patients to find out how they cope with other big things in their life and make the offer of all of these things. What do y'all think, ladies?
I can say for us and a lot of the places I've been at where there are certain patients that do go through, sometimes part of their checklist is a psychological counseling session, just recommended to be able to offer that support. Let them think of things, maybe if they're using donor sperm, things like that. But I think that it is good to have at your clinic some resources of some good, especially like you said, for talk therapy, if that's one of the ways. You're not trying to tell somebody, hey, you have to do this. It's just giving them what their options are, and having maybe some nice clinicians that work with fertility, because it is a different type of medicine, and patients have some different issues when they're going into these practices with trying to conceive and different histories. So that's what I know we have as a nice resource of some people that we can certainly refer out to the patients. And I think it's really important, like you said, Karen, as a new nurse, to check in with yourself as a nurse, sometimes just being careful to know that you have to know where your boundaries are at some point. Certainly we're part therapists, but that really isn't our complete expertise. So we have to know when we can reach out and offer the patients what they really need, if it takes it a little bit deeper than what we can provide on the day-to-day basis as their nurse. So that's just important. If you feel like you're not giving them, it's not enough, then maybe it isn't. So, you might want to look at what other resources that the clinic has that you can then put that patient in touch with someone.
No, I think that's so huge. And I also think, as being a new nurse, is also knowing our patients are emotionally charged, which they should be. They're going through so much. And to understand that, if they seem like they're calling you all the time, or they're asking a lot of questions, or they're can also maybe they're being mean or whatever back, it's not probably, they're coming from that at a place that they're really high emotion, and that's not their normal standard. So it's I remember as a new nurse and having some difficult patients, or just feeling it was me. I took that on. I was I'm not doing what they need, or and it's you don't need to take that responsibility on all the time. You do have resources. At our clinic, we have on-site counselors, which are awesome, or referring them out, but not taking it personal, because, and even patients sometimes too, I've gotten really close to some patients, and I'm man, I remember our first couple talks, we were not jiving, and they were just I just wasn't at the place I needed to be. I wasn't at my best, and I was gosh, that makes so sense. So as a new nurse, obviously all of us, I feel we are more experienced, and we get that, and we can take a step back and let those patients kind of vent or grieve to us and not take it personal. But I definitely remember, as being a new nurse, I took a lot of things more personal, or felt like it was a personal attack, or I just wasn't, it was draining me, instead of like I said, putting that off on other resources, or just knowing that our patients do come, they're not your normal patients. They've come through a long road to get here, and they are it's a very, very hard thing to go through, is infertility, and a lot of people can't relate to it. So it's just a different field of nursing and different type of patient.
Yeah. I think that's such a good point, Morgan. In probably all the medical field, we should remember that we are seeing patients on their worst day most of the time. It's just not their best self, especially, you're coming from the middle of your workday, you've had this and that already happen to you over the last couple of years, and now you've got to come and you got to tell it all again and be poked and prodded and this and that, and they're vulnerable, and it is very easy to take it personally. And I'm the same way too. I fully was these people hate me. What did I, and then now that I've been doing it for so many years, you just kind of smile and nod, and you take it, and they're not mad at you. They're just mad at life, and they need a person to talk to who gets it. And so sometimes you just have to be that person that takes it and tries to turn it into something positive that the patients can use to move forward in their journey. So it's not easy, but it's doable for sure.
Yeah, I think just taking the time, I definitely think the emotions are a little high with patients that are going through fertility issues. And when they come in, they're nervous. And sometimes it's a very long appointment. You meet multiple people during the appointment. And by the time they get to me and the plan is IVF, and I walk in the room and they just look like a deer in the headlights. And I'm okay, I know we're on information overload. I said, everything I'm going to say, I'm going to also write down and send to you in our portal. And then, sometimes if I can tell they're just really overwhelmed, I'll kind of share a little bit of my story, just letting them know that I've gone through this. And sometimes that makes people feel better, and they feel like they can, relate to you a little bit more. I've also had the patients that I pretty much thought hated me from the beginning and were, just like short with me, or, just they weren't at their best self, like you guys said. And they pretty much all of them have come back and apologized by the end of their cycle. And they're like, thank you so much. And that's why I love this field. It's so gratifying, like to see the patient get pregnant on their graduation day. I mean, that's like the best day for me. And I'll even write, if I see them coming in for their last scan, I'm like, please let Tony know, like, I just want to run over there, and just congratulate them, because it's such a long road and a lot of them feel like they're never going to get there. And, it's just, it makes you really happy for them. I'm sure it's the same for y'all too. It's just very, very rewarding.
I think you kind of hit the nail on the head with that, is to acknowledge the patients, acknowledge that you understand what they're going through, or you can't imagine what they're going through, and just help them to validate their feelings. A lot of times people feel like, yeah, I'm another cog in the wheel, and nobody wants to hear about this, but we do care. And the only patient that is important while I'm in the room with somebody is the person that's in front of me. And so I try to treat them like I want to be treated, or my family member would want treated. So just to validate and acknowledge that you do understand and appreciate what they're going through, and that you want to make it easier.
And the guys too, or the partners. Like, I love when the partners are there and you kind of get to know both of them. And then, just at the end of their journey, they're just so thankful. So it's awesome. It really is.
And by the way, one quick thing I just did want to share, specifically, Tony, there was a comment in the chat that said, thank you so much, and you're awesome for sharing your personal part of the story and how that helps relate. That all of these little stories are the things that connect with, we never know who's going to connect with what. So thank you very much for sharing. And speaking of, so this question actually just came in, and it ties in also with questions that I got, and I've been sent in advance. And so again, just kind of wrapping together the, like, I am a brand new nurse. This came in many different forms and ways people wrote it, but I'm a brand new nurse. Like, what's just some like general overall information you can share, advice for the first visit? Another way it was phrased was like, what do I do that when I come in for my very first appointment, or that first week, and somebody asks me a question that I don't know the answer to? It's really that, like, that the new jitters that we all get on, like, what do I do? What am I in for? What can I learn from the experts here who have been doing this for a long time? And that'd be a perfect segue to wherever you guys want to go from there.
So if you don't know what's going on with somebody, what the answer is with a patient's question, you got to be honest and say you don't know. Otherwise, you have permanently and irreparably destroyed any confidence that they're going to have in you. And it's okay not to know. I still talk to patients and say, I'm not really sure about that. Let me check and see what I can find out. Or I'll have to look up medications. There's so many out there that I don't know if a medicine's safe to take during pregnancy. Or I'll say, no, what are you taking that for? And, look it up. It is okay to say that you don't know. It's not okay to try to talk your way through it or dance around what the issue is, because, again, you'll lose any credibility. My advice for a new nurse is to be a sponge. Hopefully you'll have the opportunity to shadow some of your colleagues. I think it's important to shadow kind of everybody that's in the practice, not just other nurses, which is probably the most important, but also the providers, even in the lab and with embryology. I think all of those things are important, because you're going to glean little bits of knowledge all along the way. Network with your peers. This is a great opportunity here, but also through professional organizations like the Nurses Professional Group with ASRM, any kind of local organization that you have, and get involved in chat rooms. Network so that if you do have a question that you can't get answered by your peers or at work, maybe you can use some of these networking opportunities to ask other people around the country what their options are. And I think I can speak for the other ladies on the panel. We would be more than happy to be a resource to just give you that comfort and that confidence and suggestions that you may need, because we want you in the field for a long time.
I think something huge to know is you're also not going to know everything very fast. Tony, I came from like a ER ICU background and knew nothing about women's health and fertility. I went to nursing school and I was like, oh, I'll learn. And I'd say at least took me a year to feel a little bit confident, and maybe more than that. And I still learn something new every I look at meds or just new treatments, and the field is evolving, evolving so fast too, is, you're always learning. So give yourself some grace for sure. And know that you're going to hear terms and words you've never heard before, but you'll get a hang of it. And then, yeah, Karen, I totally agree. If you could shadow from the lab to this, ultrasonographers to the doctors, like everything, it just kind of gives you a full picture view, and shadowing those people kind of give you more insight of what to do. But definitely give yourself grace and don't expect to learn it tomorrow.
When I came from a similar background. Sorry, Wanda.
Oh, that's okay. Go.
I came from a similar background too. I worked in a pediatric ICU and a neonatal ICU before I went into REI, and I also knew nothing. Thought a period, when you ended your period, that was the start of a cycle. So yeah, lots to learn. So that was like, my training was so basic in that we spent 2 weeks just like literally trying, walking through the menstrual cycle and the HPO axis, and just, if you can understand the hormone cascade and you can understand why this happens, if that happens, and negative feedback and all of that, it's like the Matrix, the world of why IVF works just makes sense, because you can we're just mimicking physiology, and trying to do what would normally happen, but tenfold. And so if you don't understand the basics of the menstrual cycle and why things happen, you won't get it. So I think that is so important. ASRM has a great online course that you can take to become repro certified. I did it like 5 or 6 years ago, and it's great. And it does walk you through all of the basics of female infertility, male infertility, the medications, how they work from a pharmacological standpoint, and all of that. And so those are really great resources to use.
I was going to say, I think to remember that when patients are asking questions, to not feel intimidated by that, and use that as really, you can learn from that, because that better suits. I found when I was doing a lot of teaching, especially when we did our med classes so much more in person, all those questions just, I think, enabled me to be a better teacher, because I knew what they were asking, and it sort of was repetitive. There was a lot of things that patients were asking that then it helped me as a new nurse start to, okay. So I was learning as they were asking. And I think that was the best way to put it, is I was actually learning more. And as Karen said, if I did not know it, I was absolutely honest with, you know what, I don't know the answer to that, but I'm going to get that answer to you. And, be impeccable with your word. If you say you're going to do something and get back to a patient, get back to them. I know our patients sometimes feel like we have to get back to them right away. But you might say, you know what, I may not have that answer today, but I know I will get to you definitely tomorrow. So give yourself a little leeway so you don't feel that pressure just in case you can't get to that answer today. But, the idea is, I would say, if you are going to do something for a patient, really make sure that you're saying that to them, that you're doing it, because that's a big thing. As Karen said, like, it's trust. You want to create that, they're trusting in you when they're asking you questions, and no question is stupid or silly.
And I think it's huge. Like, you don't have to know the answer. Like, coming from different backgrounds, ER, ICU, a lot of times, like, you needed to know the answer because it's a life and death situation. Mm-hmm. And with women's health, infertility, it's not. So you can have it. It's okay to, because you don't have to have the answer right then and right there 99.9% of the time. So definitely that kind of helps too, especially as a new nurse, is like, it's okay to ask questions, or okay not to know, because you don't have to. Or you can ask someone you're whoever you're following or you're orientating with, and it's easy because you can put them on hold or just say, hey, I'm gonna run out and ask this question, because you do have the flexibility of not having to know that second.
What I think is funny is, coming from like the ER, and I know y'all can probably attest to this, you probably think you've like seen it all coming, you know, you see all kinds of stuff there. And I'll never forget like my first day, and I did that for like 9 years. So I was pretty established as a nurse when I started in this field. And this patient walks in with like the brown bag, and they handed it to me, and I was like, oh. And it was like an IUI, and I was like, oh, we're doing that like right here in the room. Okay, let's do this. And I just remember being so like taken aback by that, and I was like, wow, this is really happening right here. Okay. So I learned a lot. It did take probably about a year before stuff started clicking for me. The doctors are great resources. I think actually seeing some of the procedures is really interesting for new nurses, like going and standing on egg retrieval and a transfer. And I remember going to Start Art, and that was extremely helpful. So I don't know where all that is at with COVID, but those are really good resources, and ASRM, and just, you know, joining your accreditation programs. And so, but yeah, you just lean on your nurses, lean on your doctors. Definitely don't answer a question if you don't know it, because that patient will not forget that you lied or, you know, didn't give them the right answer.
One quick thing, actually, because this just came up as part of the answering what your question was. I know we touched on a couple things like the ASRM, the crash course on, you know, the reproductive cycle and all of that. Just wondering, and obviously if you guys don't, this is, you know, you didn't pre-screen any of this stuff. So if you don't have answers off top, we can always make sure that we get the stuff, and we'll put it on the Facebook page as well. But question just came in, like, what are some of the resources that you would recommend to some, maybe like a new nurse that came into your clinic or something like that? So if there is like a general overall, you know, like websites that you use, or books that you think are helpful, or anything like that, courses that are helpful resources for somebody just to kind of get up to speed when kind of everything, they're just absorbing everything in the beginning. So no detail would be too small, if you have any ideas.
One thing I would suggest is take a look at your company's website. I think a lot of us tend to be working for our clinics, and we forget that our clinics have a great, you know, a lot of websites are out there representing your clinic. And sometimes I've forgotten about that, and I go on and I say, oh, wow, we've updated this, or we're saying that, or whatever. So I really think that's helpful, because a lot of times our patients may have found us somehow. They may have perused very little. And I've asked even our patients and new nurses, I'm like, have you gone on our website? And even the new nurse is like, no, I actually haven't. I'm like, there's a lot of information in there, like about IVF, IUI, you know, LGBTQ community, egg freezing. And it's really not just coming from our perspective of the practice, but absolutely from just in general. And I think that's a good way for a new nurse to maybe know your clinic and really take a look at that if you do have a nice established website there. So I think that's one suggestion I could say, because I know I do it every once in a while myself, because I know we're updating it. So it's good for me to go on as well.
Yeah, and I know the ASRM is a same thing as Roxy said, is awesome. I don't know, and that might just be my clinic. I had to be there for a year before I could get certified, but that might just be my own clinic. Do y'all know if there's a time limit before you can take that course? Anyone know?
I believe it's a year.
Yes, yeah. Yeah, because I think it's so many hours that you've worked in the REI field. Yeah.
We direct some of our new employees to the Resolve website. They do almost like a 101 type thing, like we're doing tonight, and they go through, you know, what infertility is, male infertility, and just explain the different diagnosis and procedure types and stuff. Our physician too, I agree with Wanda, our website is fabulous, you know, and our doctor had wrote like an IVF guide, and we have an IUI guide, and we give that to the patients at their new patient appointments. But I also am like, why are we not giving this to our nurses, you know, because it really breaks up everything, talks about the meds, talks about what to expect, the procedures, you know, what happens after the procedure and stuff like that. So, I mean, those are really good resources too, if you have stuff like that.
Mm-hmm. All quiet.
Craig.
All right, no, it was me. I was trying to get my camera to turn back on with this spooky background that for some reason keeps popping up. And yeah, if of course, ladies, if you do think of anything else, let me know. We are posting some things into the chat of this program. So if you guys think of anything after this program's up, we can always go back and add some more to it. Obviously, I would be remiss not to mention the MyMandelsPharmacy.com website, where we have plenty of different videos. We have information. We have blog posts, some that are, that kind of cross over between patient specific, but also to if you're a new nurse, a lot of that there's a lot of overlap there. So we try to bring as much of that information as we can back together, such as this program, the pharmacist program, where you can find conversations between other nurses and so forth. And there's plenty of websites that we could probably direct you to where there's just chat, where people ask questions, just put out there and ask questions to find out. Because if you have a question, guaranteed there's many other nurses going through a similar situation that also have the same question as you. So it's a great question right there. Speaking of, so now we've gone from kind of the early part of things, like some of the more general, hey, I just have questions about or resources or whatever, into something that's a little bit more specific. And this question came in that said, why would my patient actually end up doing a simulated versus a natural different protocol versus like an FET or something like that? So like, what are the reasons why patients are coming in for those different reasons or for those different cycles? So you can have a better understanding of who you're treating and what their background is when they come in the door.
Okay, I'll go for it. It's all going to depend on what's going on with the patient. So it may be that the patient is having difficulty figuring out when she ovulates. It may be that she is using donor sperm and just needs to make sure an insemination is timed just right. So in those cases, she may not need medications if she's ovulating fine on her own. However, if she's a little bit older, a little bit more eager, perhaps she has some ovulatory problems or multiple ovulatory problems, she may need specific medications, either oral ovarian stimulants, or to be more aggressive still, she may benefit from injectable gonadotropins. And with IVF in this country, it's customary that patients want to retrieve more than a single egg. So we'll use at least injectable gonadotropins and sometimes some other medicines as adjuncts to that. So the short answer to that complicated question is that you want to make sure what the patient's diagnosis is, what her goals are, and what her overall picture is, including her age, her desires, and the treatment that she's undergoing.
I think I heard Craig say too that the question was maybe also in relation to like determining the type of embryo transfer cycle that might work best for a patient. And, a lot of that is probably clinic specific. I know that, many clinics have a preferred protocol for how they want to proceed with putting a frozen embryo back. And a lot of it depends on, are you working in a clinic that's a big clinic and you're open 7 days a week and you're doing monitoring 7 days a week and transfers fall when they fall and weekends and holidays are all the same as a Monday or a Tuesday, like it's all the same. And so a lot of those places will offer different types of protocols to use because there's more flexibility. Some clinics will use just a standard approach, which is essentially just taking over someone's body and again, mimicking physiology, quieting the ovaries, and then starting progesterone and putting an embryo back so that you can synchronize the age of the embryo to your uterine age. But that doesn't work for all women. And sometimes these exogenous hormones don't make a nice endometrium and they don't result in a good pregnancy or a good outcome. And so those women might decide to use a stimulated or a natural approach, depending on, again, just like Karen had said, it often depends on what your ovulatory status is. Of course, if you are in ovarian failure or you have PCOS, you can't do a natural cycle because you're not going to make an egg on your own. And so you may need a stimulated approach where we can make that happen for you. And so, the decision to do that is often dependent on the clinic, but also based on what works best for the patient. And some women want to try a more natural approach without taking all of the hormones and just kind of slip an embryo back at the right time. You know, and a lot of it, I know where I work here in North Carolina, where we don't have state mandates for infertility treatment, so much of the decision process has to do with what can patients afford? What does insurance cover? Is this stimulated cycle going to cost me $4,000, where a natural cycle might cost me $100 to buy a trigger shot, and that's all, you know? So it just depends on, you have to kind of take all of these things into account. When I used to work up in Manhattan, this was not a question. You just did whatever was the best thing because everybody had insurance coverage and everybody had access to meds, and it just wasn't, the financial aspect of it was never up for debate. But it's different. It's different down here where you do have to take all of those things into account.
Yeah, I agree. That's kind of how we do it at our clinic too. We don't have a lot of insurance down in Louisiana. So we're seeing a lot more coverage though lately. So I think that's interesting too. Maybe that equates to why we're having more patients as well. But we do typically start with like the standard protocol and then just kind of assess from there. If we have like a failed transfer, sometimes if they have regular cycles, we'll try a natural cycle. I will say the patients really do appreciate the natural cycle a little bit more. And I think it's a little bit easier for them. It's a little more comfortable. Not quite so many injections. I think it's interesting how many people come to us on their very first patient appointment and are already talking about progesterone and oil injections. And I'm like, we're not even close to that yet. So just like, let's just put that on pause. But you know, those are probably the roughest ones out there.
Awesome. Perfect. Well, thank you very much. A couple other, I guess, a little more on the specific side of things. So feel free, like, you don't, if we don't have, if it's a pretty short answer, we can move right on. But how does luteal phase HCG work? A little bit more specific there.
So we do this protocol a lot in our clinic. One of our providers, Dr. Bruce Lessie, has devoted his life to research on endometriosis and recurrent pregnancy loss. And so we're working on recruiting patients for a study right now with recurrent pregnancy loss and offering them an HCG booster injection a week after their first trigger. So a week after ovulation, you give them an HCG trigger shot. And the theory behind it is to stimulate the corpus luteum. You know, as you know, about a week after ovulation, you hit a peak progesterone level. And then, you know, oftentimes if there's no pregnancy, the progesterone level could potentially start to trend down. And so the goal is to keep that going. So if you can give another booster shot a week later, you'll stimulate the corpus luteum to excrete more progesterone to help to keep a pregnancy going. When, you know, usually around that time, especially for women with a recurrent pregnancy loss, they may start to have implantation and then end up with implantation failure and an early term loss. So we've seen great results with it. It's really fun to see, you know, such a simple approach, you know, and a lot of these patients, you know, you may think we need to do IVF and PGT, and what's the reason for the early losses that these women are having. And a lot of it is just about correcting luteal phase defect and increasing implantation chances. So it's going to be neat to see the study data come out. From the preliminary data that we have, it's really encouraging. Do you guys do that at your practice at all?
We've just, with our natural cycles, we would trigger and then 2 days after their transfer, do Lupron again. So like another, not but Lupron, but same kind of thought, you know, to help influx that increase of estrogen and progesterone for that. But, and also I think even before that, they used to do it like a week later, like probably your clinic, and that's probably that study is coming from. So I think it's super interesting, but it makes sense. I mean, like from a physiology standpoint, but we just started doing that, I would say like 2 years ago, but just.
Yeah.
It was actually fairly commonplace in the 1980s. Patients who were getting gonadotropins or doing IVF got an HCG booster about a week later. And sometimes a smaller dosage a few days after that. There are a couple of risks before y'all all run home and try to do this. One of the risks is going to increase hyperstimulation. As you know, women who get pregnant with doing that have had their ovaries stimulated are a little bit more likely to get hyperstimulated, where their ovaries swell and they have pain and can have nausea, vomiting, diarrhea. Their pain can be so bad that they're hospitalized for pain management. And there is a shift of the fluid, third spacing, so they can have free peritoneal fluid. And there have even been deaths reported from ovarian hyperstimulation. HCG given in the luteal phase does increase that risk. So it's likely going to be from carefully selected patients. And I would just, I think it's a great idea. It does work. But there's kind of been a shift over time to use progesterone instead. I'll be interested to see how Dr. Alessi's study comes out. And I wouldn't mind seeing a resurgence of that in selected patients.
Yeah, that's a good point, Karen. We actually, a lot of our patients who are using this approach actually do just natural cycles with timed intercourse. So they don't undergo any ovarian stimulation, which is kind of great. Yeah, I do think our patients really appreciate that approach, in that instead of going all in, like do all the things and spend all the money and all the time, it's like, you know what, just track ovulation, let us know when you ovulate, we'll tell you when to take the shot, let us know if you're pregnant, and I think taking this major stress off of all of it is really helpful for a lot of these women, especially because as we know, stress can play such a big factor. But yeah, it's a great point, Karen. Of course, yeah, we do have to take into account OHSS, and certainly we've seen a decline of that in recent years, especially with Lupron triggers, and it's no fun to bring that back into the clinical picture.
Hey, Roxy, question for you. Just curious. So you do it in like basic patients. Is there a difference between just giving them progesterone, like compared to a trigger shot 10 days later?
Yeah, so that's part of the study that he's working on. But we do find that the progesterone, it doesn't have the same endogenous flare effect of the corpus luteum stimulation. So, and many of these women have been using progesterone kind of on their own anyways, from their OB may have given it to them. And so we do find that their success rates are slightly higher with the HCG trigger, with the booster rather.
You'll have to send that study to us.
Yeah.
Awesome. All right. So thank you very much for all of the information there. We'll have to follow up and try to loop everyone back in together to talk about it when we have more information about that. So thank you, Roxanne. That's awesome. One thing that came in, I think, again, this is kind of maybe taking a step back into some of the emotional side of things, or emotional aspect that nurses will be dealing with early on. And the question came in a couple different ways, but really boils down to like when the patients that are not pregnant, the patients that we don't get the outcome that we're looking for. It came in a couple different ways, like how do I handle those conversations? One person's asked, like, do I save them for last? Is that like the last person I should call? Go reach out to the ones who got pregnant first. It's kind of more just in the conversation of how to handle that, because those are, especially early on, that's the part that we're not looking forward to, right? So we don't practice that as much as we should. And so getting that help from the experts who have been dealing with this and have had those conversations before would definitely help some of our newer nurses.
Well, I think what you don't want to do as a nurse is call up somebody and say, your outcome was not pregnant, so just give us a call with your day one and bye-bye. I think that we have to, Tony and I sort of chatted a little bit before starting and agreed that, you got to take a little extra time, if you can. You really want to offer continued encouragement, knowing that you're the clinic and you're not throwing in the towel for them, even though this outcome is not pregnant. So you want to hold on to the positives, especially if they had a nice response to their cycle, but it was textbook. And I've said that to a patient. This was like a textbook response. We would have loved to have seen a pregnancy. We're here with you, and it disappoints us as well. But we're moving forward, and what can we do to help you to get from that not pregnant to that next step again, even if it's a repeat of the same cycle? I think the first thing a patient will say is, does my dose need to go up? Do I need to change anything? And sometimes you have to say, nope, everything really was right on track. It just might take another egg to recruit to get that positive cycle. So certainly I think it's just your approach in saying that. And I did share with Tony that at our clinic, what we instituted was we really did feel like for our IVF patients and our frozen embryo transfer patients, because there's so much involved in those types of cycles, our physicians do make that call if it's a not pregnant. And they really do that because we found that we were getting lots of questions and spending lots of extra time with just one not pregnant, where we felt like it would be more efficiently handled if the physician spoke to the patient and could really say, okay, this is what my plan is, and I'm going to talk with my team, and here's what we're going to do, like to kind of let them move forward as well. So I know our patients have actually, I think, really benefited and appreciate maybe that approach. Not that we're not capable of giving them the not pregnant, because we always did, but we actually just enhanced that a little better so that we could move forward more with that next step in a more efficient way.
I think it's kind of interesting that patients are looking for those cues. Just like Craig said, you call them off first, you call them last. How do you do it? And I remember I put on a meeting once, a local meeting, and I had a panel of patients that talked. And one of the patients said that she always knew the later in the day it got, that meant it was less likely she was going to be pregnant. Well, that kind of broke my heart, because I never want somebody to think, oh, well, you're not fun to call, so we're going to call you last. So what I try to call I'm the one that calls all of my patients. We thought about doing it different kind of ways. I call with bad news, somebody else calls with good news. I don't really think that's fair to the people that are on one end or the other. Nobody wants to be the one to call with all the bad news. And I think when you do tell bad news, it helps you to appreciate the good news even more. So we've done a couple of things in my practice. One of them is I've tried just to call people in the order I get the results. Whoever's on top, I call them. But more recently, I call the people with bad news first, because everybody is anxious. Everybody is worried, whether they're pregnant or not. And I don't want them to think that they are the least important because they're being called last. Certainly they're the hardest, but I let them know early on. And I tell them at that point, look, we meet as a team, actually the day after we do the last transfer in a particular series. And we have a plan for you. I am so sorry. We are devastated, and I know you are. And we care about you, and we want to help you. And I know the thought of going through something else is not what you want to think about right now, but you do want to have a plan moving forward. I want you just to take a minute and take care of yourself right now. And we're going to make an appointment for you to come back in. We'll sit down and go over everything. Another reason, and I'll answer whatever questions they have right then too, but I don't think that's the best time to have a full consult, because they can't think straight. Another thing that that's kind of along those same lines, the patients that are positive, they get their calls last. When you tell them good news, they don't care if it's 7:30. They are just happy to have the good news. So I would rather break the bad news to people early on. It also helps that I end my day on a positive note, but I still keep those patients that are struggling in my heart to know that they have negative news. I have patients that ask me, and I'm sure you ladies do as well, was it a good series, or did you have lots of positives this time? And I'll say, I'm not going to think we had positives, but I'm not going to think it's a great series until everybody's positive, because I think of everybody as an individual, not as a bunch of numbers or a component of statistics. So that's just food for thought. That's what's worked for me.
And I think it's important to also make sure you're posturing yourself before those bad calls. Making sure that it's not super loud, or that you're just, because you might make, hopefully not make a lot of these calls a day, but you could have 5 of these calls a day, and you're just delivering news, but to that person, it's the worst news they've heard, especially after, I think, an IVF or FET. And I always try to make sure I don't, I think just when you get the news to call them, because ripping off the Band-Aid waiting isn't going to help, but always to make sure that it's not in a time of day where the office is super loud or there's a lot going on. So you're giving your full attention to that patient, I think is really important. And to like listen. And I think it's true. Good too is like, I always tell my patients, I'll let you digest it and call me back as when you need to, or, we can discuss this later, because they aren't going to process anything at that time, other than like their sadness.
Yeah, I think I have a hard time too. Unfortunately, I don't get to call as much with the pregnancy test as I used to, and I really miss that. Even the hard ones, I don't mind making that call, because I do feel like I take the time and try to help them on the phone to process it. But I hate calling with negative PGT reports. It is so hard, because like they're so excited, and like everyone's always at work, and I'm like, maybe, do you need to step outside? Are you ready? I have your report. I'm going to go over it with you. And I've caught myself doing this lately, and I didn't even realize I was doing it until Juan and I were talking about this. I mean, I always call the abnormal ones first. Like I try to, because everyone's anxiously awaiting their PGT report, And so those are really hard calls to make, because then they feel like, now I got to start all over, So.
Mm-hmm. One of the things we do in our, I don't know if it's right or wrong or what have you, but we primarily communicate with our patients through our patient portal, which I'm just on all day, because I'm at various computers throughout the day, and I'm not always at my desk. And so patients rarely call me personally. Usually they reach out to me via the portal. But we usually tell our patients that we will message them with their pregnancy test results. And we find that so many patients are thankful that we're doing that, because they are at work, or they want to wait and review they want to hear it or see it when they're with their partner, and they can process it together. And to get that phone call in the middle of the day, whether it's a good call or a bad call, it just like throws your whole day off kilter, and you can't really move forward from whatever that result was. And so unless a patient is like, I have to talk to someone on the phone, we do find that patients tend to appreciate the message, so that they can read it when they want to, they can reread it when they want to. Half the time when you call them and tell them what their numbers are, they don't hear you. They have you tell them that they're pregnant, it's a great number, and they're just like, whoosh. They need to have it repeated 10 times anyway. So it's nice to, I think, sometimes be able to look at it and read it and see it. And sometimes they even want to look up, what does that mean? And what are normal parameters? And then send their questions back to me throughout the day, so that we can respond.
We do have a good bit of requests for people that come in and they're like, please don't call me, just send me a message.
Yeah.
So, we definitely do that as well, if that's what they prefer.
Yeah, we have some that will say call a partner. And
that
call
too.
them, because it's easier to them to be reached, and we'll do that. But we'll call and then follow up with portal. I think the tougher calls are those betas that are positive, but aren't
low.
but are low. That's a tough call, because you're always trying to be somewhat optimistic, because I'm sure we've all seen there have been some low starters and they've moved forward and they've been fine.
We all know those babies that started with a beta of 5.
Yeah. So, you always want to offer hope, but you want to be, manage the expectation, but
it's funny you guys. It's funny you guys say that, because I just had a patient graduate last week, and her beta was 7. And I remember having to prepare her for that first call. It was an IVF patient, and I was like, I'm just letting you know, I'm not sure if this is going to go up or down, but we're just going to have to keep watching the level. And she was so appreciative. She said that was I think she'd done IVF cycles in another country. And so this was like her 5th or 6th round. And she said she'd never gotten a positive. So this was the best call of her life. So it's I was like, it was really strange, because I'm like, well, it's 7, not sure. Well, we just got to keep watching it. And then she just graduated the other day. So that's my story, to keep hope when it's low. You just never really know.
Yeah,
exactly.
I'm sure it obviously helps, just for anyone out there, also just to remember those types of stories, right? Where it started out and it was a little bit nerve-wracking, and it did pay off, because that's what helps you moving forward, having those conversations, to be able to you know, to know that you're not just saying what you think they want to hear, but you're actually speaking from the heart of like, hey, I've seen this happen before. And so I can be honest right now and say, we'll watch and see what happens. But sometimes it's just for your own, ability to make it through the day, which is very helpful. And one quick question that came up, and I just want to get to it because it just popped up. It's a little bit more specific. So want to see your guys' thoughts. How does a patient fail a trigger, whether it's Lupron or HCG, besides an issue where they made a mistake with administration of medication or missed, time-wise, something like that? Just something, even if there's only one or two answers on it, it's fine, but just wanted to throw it out there to get your guys' thoughts on that.
I'll take
it. Maybe depending upon which type of trigger it was that was administered in that cycle. BMIs are important, meaning body mass index. If maybe something just didn't absorb in a little subcutaneous injection, so we might switch it to intramuscular. That could be a possibility. But sometimes it just happens, and I don't even know if we've often we'll have patients bring in the vial. We check it to make sure. We've even tested sometimes if there's a little bit in there and sent it to the lab to see if it rings up in the blood lab. But oftentimes it's just, if it fails, then we just re-trigger and move on. Like, we can't stay stuck in the why didn't it, what happened, but because we want to salvage that cycle. So usually that has occasionally happened at our clinic, and then the patient's re-triggered and been fine and retrieved and been A-okay. So I guess I would want to reassure that it has happened. I know it's happened in our clinic, and usually if we re-trigger and set up that retrieval, everything goes as usual at that point.
Yeah, one of the things we worry about a lot with the use of Lupron triggers more and more frequently to minimize OHSS is to making sure that patients have a really good communication with their HPO axis, and if they don't have communication and their ovaries and their pituitary gland aren't talking to each other, then Lupron failure is inevitable, and those patients will go to egg retrieval and have nothing to retrieve. And so we will often check baseline hormones, FSH, LH at baseline to get a good sense of if those women have a good communication. Sometimes even when their labs are okay, they still will fail a Lupron trigger. And so we're always really nervous to give pure Lupron, and we often always want to give a little bit of HCG as a backup. But it's funny, there's tons of centers out there that just do 100% Lupron triggers, and it just really freaks me out. I don't know how they trust it. Especially with we're not open on the weekends. And so if we do Lupron triggers, we'll have patients test OPKs the next day, which can also be faulty too, and so without checking labs and getting 100%, it's just, you don't know what you're going to get on Monday morning. It makes you nervous.
We do check the labs post-trigger. So
yeah.
I don't know if everybody routinely does that, because I've been to some places that haven't at times, but I mean,
do you do that for HCG also, or just Lupron?
Yeah. For the trigger day, and then the day between trigger and retrieval, they come in for blood work only. We used to do ultrasound, but right now we're just doing blood work. We're not even doing the ultrasounds anymore the day before the retrieval, unless there's something that there's a reason that warrants it for a particular patient. So I think to the person that might be asking the question, I would just want to reassure that this can happen, but it's probably, as we all might attest, few and far between, which is a good thing. Yeah. But there's that little window where somebody can fall into that category.
Oh yeah, I think very few and far between, especially now. I think most clinics do post-trigger labs, so checking blood work the day after they trigger. And also, I think a lot of times patients might know if they're hypo or they're not going to respond to Lupron. But yeah, like you said, one or two. I've had a patient who had normal labs, no idea, post-trigger labs were fine, and she ended up not responding to Lupron. And then it's just something you're like, it won't happen again. But I maybe could count on one hand how many times that's happened in my 8+ years of doing this.
Mm-hmm.
Perfect. All right. Well, I do have one. I think this is a perfect way to wrap this up, because it is kind of overarching to everything that we've been talking about, and a lot of these questions that we've already addressed, and then specific questions that came in a number of different ways that all really got down to the idea that people say this job can be very stressful for a lot of the reasons that we've just talked about, the conversations that you're having, the people that you're dealing with who are sometimes not in the, they're going through something very difficult that are, sometimes maybe that's projected outward a little bit towards you. So for all of these different aspects of the job that can be sometimes the hours, all of the things, how can I, and this is again coming from the nurses saying, how can they take care of themselves? What's the best way to take care of yourself so you don't carry over all of that baggage from one day to the next, so you can, bring the good stuff with you and try to compartmentalize the bad, or learn from the bad and then put it away. Just what are some things that maybe you guys have used in the beginning or things that you still use now, techniques to help yourself just kind of really take care of the nurse so that you can help take care of the patient and help them get pregnant?
Well, I'll start with this one. I think that we all need to put on our own oxygen mask before we help those around us. So it is important that we take care of ourselves. But the thing that keeps me going and has kept me from being out despite all of these years of doing this is that I am eternally thankful every day that I have the opportunity to play such a vital role in patients' lives. For many patients, we're the lifeline. We are, I hate to sound like we're Obi-Wan Kenobi, but they think, we're their only hope. And gosh, that is such a powerful position to be in. And I don't take that for granted. And even though it may be one difficult phone call for me, that is this person's entire life. That is all their hopes and dreams wrapped up in that one phone call. Every visit, every ultrasound, every encounter that we have with a patient, that is the world to them. And I think once in my own heart and in my own mind, I realized what an important responsibility that I have to value those moments and to take every one of those moments seriously. I think that made me a better person and a better provider. And my goal is to make every experience for the patient positive, whether their pregnancy test is or not. And at the end of the day, I can put my head down and often get some rest, not always. I would tell people don't take your work home with you, but that's impossible. You're going to take it home with you. And one thing that I have told my colleagues over time, they get frustrated with a particular patient or a particular situation. I'll say, look, this is maybe 15 minutes out of your 24-hour day. That is such a tiny little time period for something that's so important. This patient has been worrying about this for days or weeks or months or longer. So I think if we can just accept what responsibility is being bestowed upon us to be these patients' lifeline and to walk through the day with her, we should all be able to walk away at the end of the day and hopefully appreciate that we're doing the best that we can and we're there to serve the patients that come to see us.
No, I love that. I feel like, one, we're nurses, and no matter what, we're going to take our jobs home with us, no matter what kind of nursing you do. That's why we got into this field. I definitely, infertility is stressful because I think that we take the stress of on our patients. But like Karen, you were saying, it's so rewarding. For me, at work, I have a baby wall of all the birth announcements or photos from my patients that they send in. And it's literally right behind my desk and covers my wall. And it's such a good reminder, if you're dealing with a stressful patient or I'm stressed out or, work is crazy. And I look at my baby wall and I'm like, oh, this is so worth it. This is why I do it. And the relationships you build with your patients, we are their lifeline. I still talk to a lot of my patients today and they still send me Christmas cards. And it's a field of nursing that I don't take for granted. And yes, there are super hard days. But I think there's hard days in any job and any nursing job. And this is one that you actually can build such good relationships. And the joy that I get after graduating, Tony, you said too, their graduation day is one of the best days ever. You really do. And that's something that I don't mind taking home with me because it's why I became a nurse. And I think that as new nurses and things like that, definitely it's harder to compartmentalize and to realize that. But as you start building these relationships with your patients, and as you start learning that, you'll really enjoy and come to love the field of nursing that you're doing.
Morgan, I love that, the baby wall thing, because that just makes me think of vision boards, which is something that they talk about, some way to do some self-care is to surround yourself with the things that bring you joy. And that's a way to bring in what you're doing and joy. I see a lot of our patients in the early morning. I'm like the early morning monitoring nurse with a lot of things going on. And I'm going to admit, in the beginning, I was awful at this. I really was so stressed out a lot. I just felt that pang of the patient's pain, and had to really work on myself a lot throughout the years. So this has been certainly a journey as a nurse to get there as well. As Karen says, we all have a journey. And I think you're only as good to your patients as you are to yourself. And I think sometimes as nurses, we are not always doing some of that good self-care. So one of the little things I do in the office now, and I get a lot of comments from patients, is the little morning monitoring room, the patient room. I have a little salt lamp. I have a little essential oil going. I have a little light music that's just it's very light. And every patient that walks in the morning is like, I love this room. And all the colleagues do. And I'm like, well, it's just my little sanctuary for me so that I'm in a good space for them. And it definitely makes a lot of difference. It takes that toughness of the mornings where everybody's up early, they're tired, maybe they came in and heard about a loss. It's difficult. So I just surround myself, like you are, with that vision board of something that can maybe bring positive for a patient. But every patient comments that has never been in that room on occasion and they're new, they go, wow, I like it in here. So it's just little touches, but they've gone a long way. For me anyway, that's what I've done recently.
Yeah, we kind of do the same thing. I mean, I can't say what I do to check out at home or after hours. It's kind of hard these days, but I do love just kind of actually driving home in silence sometimes, just because it's been a long day, talking on the phone, talking to patients, having hard conversations. And I know my sister-in-law, if she is watching, she'll be laughing at this, but I've got a lot of plants and I made a Zen den in the backyard. So when I get home and everything's crazy, I'm like, oh, I've got to go water my plants. And so I'm outside watering my plants, nice and quiet. But our office has a really nice feel. I love being at work. I mean, we have a really, it's an old shotgun house. So it's more like a house. And so you really do feel at home here. I feel like as a patient, all of our nurses have their own diffuser. So there's a lot of essential oils as you walk down the hall. So it is very, very calming to be here. And, so I think that really helps.
I gotta say, I'm definitely a huge fan of the concept of the Zen Den. That sounds like the much more adult version of the man cave that we.
Yeah, it is. It's the man cave on the weekends for football, for sure.
There you go. All right, perfect. Well, thank you so much. I think that was the perfect question to kind of wrap things up, because we can go from we can talk for hours and hours and hours more about some of the more specific things and some of the more the medical questions, or the kind of answering the specific things that are going to come up in the clinic. But this is a great way to end it, is understanding that it's all about you, and you can only help so much as you possibly can as long as you take care of yourself. And that is really what this whole program has been about tonight, is to really share that information that can help you be the best version of you, so that when you are seeing your patients, all you are doing is helping them through. Even when it's difficult, you're there to help them to get to an ultimate end game, and to make that process as smooth and as enjoyable as it possibly can be. So first off, I just want to say thank you so much to our amazing panel. Thank you, Wanda. Thank you, Roxanne. Thank you, Karen. Thank you, Morgan. Thank you, Tony. Everyone, you guys did such a great job. I love all the stories that you shared, and you've been seeing a lot of the comments that have been popping up on both Zoom and Facebook, with people just saying thank you for sharing, or thank you for telling that story, or that helped so much, and all of that. So it really all comes down to you, and we really do appreciate your time. And obviously, to everyone at home who has been watching this program live, or if you sent in these questions beforehand and you're going to enjoy the program on demand and check it out, thank you so much. Obviously, this program couldn't be anything without your involvement, because that is what the whole pharmacist program is about. It's about bringing us together with our nurses and to be able to talk directly to patients, talk directly with other nurses, and really share our knowledge so that we can all learn and be best as we possibly can be together. These programs happen, we do these about once a month, the nurse panel. And so the information, we will send it out there. We'll put it out on our Facebook page and on everything that we do social media wise to let you know when they're coming. We also do every Monday night at 7 p.m. Eastern. We have our virtual learning experience where we go through 3 or 4 different medications. And we actually have one of our nurses present those medications and then answer questions live coming from patients or nurses or any of the above partners. It's open to anybody. And those programs are also live as well as on demand. So you can go ahead and check out the entire program live and be a part of the conversation, or you can always go check it out later when you have a chance, or whenever you are, working out or whatever people are checking out the videos. That's what we're here for, is to make it as easy as possible for you. So you can find them all on our Facebook page, our mymandellspharmacy.com/pharmacist page is where all of these videos also live, our YouTube page, all of that. So you can check those out, subscribe and like our page, and you will always find out when something goes live. So you can be a part of the program that way. So again, thank you ladies so much for sharing all of your wonderful information tonight, for sharing your personal stories and really helping us get in the mind of where you were way back when you started, so that one day we will be able to be the experts sharing the information with the next generation of nurses going through the same conversations that we've been going through for 40 plus years. So great time. Thank you for everyone who's been at home. We look forward to seeing you at our next one. And it's been a great time. My name is Craig Orapello. On behalf of Mandells Clinical Pharmacy, I want to thank everyone for being a part of the Pharmacist Virtual Learning Experience. Have an awesome night, and we'll see you here next time. Bye-bye.
Good night, everybody. Good night, Chris.
Bye.
Thank you.